Welcome to Webisode 2 on the 8-point criteria for take-homes. I'm Eric Morse, an addiction psychiatrist who's been working in opioid treatment programs for over 18 years. According to federal regulations found in 42 CFR 8.12 and explained in more detail in Tips 43 or 63, the medical director of an OTP can grant take-homes if the individual patient meets all of the following 8-point criteria. The medical director can make take-home decisions more easily with input from the entire treatment team. The first of the criteria is to consider the absence of recent abuse of drugs, opioid or non-narcotics, including alcohol. Keep in mind that we're talking about abuse, not use. So if the patient is drinking alcohol minimally or rarely, it is up to the medical director to determine if the patient is eligible for take-homes or if the patient is prescribed opiates or stimulants for legitimate medical reasons. Next is the patient attending the clinic regularly. The patient must be attending daily with excused absences. The medical director or counselor submitting the take-home request and treatment team can easily look at the patient's dosing history in the electronic medical record. Third, there must be an absence of serious behavioral problems at the clinic. This is why having the entire treatment team giving feedback to the medical director to make the decision is extremely helpful. Patients may behave differently for the medical director versus the nurse, the counselor, the front desk, or with the security person in the parking lot. The fourth point to consider is the absence of recent criminal activity, for example, drug dealing. If the patient is engaged in criminal activity, the patient would be at higher risk of diverting their take-homes. The time frame of how long take-homes should be revoked is unclear. I usually revoke them for at least 3 months and make them earn them back as if they were new patients. If my methadone take-homes were sold, I may not allow patients to earn take-homes again for at least a year. The counselor and the entire team would have to note significant change in the patient as well. Next, consider the stability of the patient's home environment and social relationships. If the team and medical director know that the patient has an unstable living situation, be it domestic violence, homelessness, or still living with people who are actively using, the patient may not be able to adequately protect their take-homes from being diverted. This is where mental or emotional stability may be considered. Sixth, you must also consider the length of time in comprehensive maintenance treatment, because North Carolina regulations found in 3600 is stricter than federal guidelines. North Carolina allows for only one take-home in the first 90 days of treatment. After 90 days of continuous program compliance, the patient could be eligible for a maximum of 3 take-homes. After 180 days of continuous treatment and another 90 days of continuous program compliance at the previous level, the patient may be eligible for 4 take-homes. After 270 days of continuous treatment and another 90 days of continuous program compliance at the previous level, the patient may be eligible for 5 take-homes. After 364 days of continuous treatment and 180 continuous program compliance days at the previous level, the patient may be eligible for 6 take-homes. After 2 years continuous treatment and a year of continuous program compliance with 6 take-homes, the patient may be eligible for 13 take-homes. After 4 years continuous treatment and 3 years of continuous program compliance, the patient may be eligible for 27 take-homes. The 7th criteria includes the assurance of take-home medication can be safely stored within the patient's home. Again, the treatment team and medical director must be able to determine if the patient can keep their take-homes safe at home. There cannot be roommates or family members who are going to steal these take-homes. It is more than just having a lockbox. The final criteria requires you to weigh whether the rehabilitative benefit the patient derives from decreasing the frequency of clinic attendance outweighs the potential risk of diversion. So if the patient has a job, school, or volunteer work to go to, or family to look after, it benefits the patient to not come to the clinic. The medical director can give take-homes. If they work from home, I ask for a 1099 or a W-2 to prove legal employment. Also, medical stability may be considered here. It's not just diversion that we need to be concerned about. If the patient is no longer medically stable, the benefits may not outweigh the risks. If the patient is suicidal and could overdose with their take-homes, allowing take-homes may not be appropriate. The same 8-point criteria has to be considered when submitting CSAT extranet exception requests for special take-homes and not guest dosing a patient. I would rather guest dose a patient who does not meet the 8-point criteria, but still needs to go out of town for an important reason, if there's an OTP within reasonable distance. The 8-point criteria also need to be considered when revoking take-homes when the patient returns to use or becomes medically or mentally less stable. I typically tell patients that take-homes are consistently being evaluated and are always a treatment team decision. If you have further questions, please feel free to contact your state opioid treatment authority. Thank you for watching, and keep up the good work.